So I'm not really going to talk a great deal about Inala Primary Care. I'll mention it occasionally. I'm proud to be the CEO of charitable general practice, so we are a little different. As Brian has said, we work in one of Queensland's 12 most disadvantaged areas. We have 23 doctors working out of our facility, a team of allied health, and a total of about 42 people that come in and out of the facility each week. So it's a wonderful team of people. And they challenge me, they stretch me, and they push me all of the time. So part of what they did was they pushed me out of the office last year for 3 months, and the team went swimmingly well whilst I wasn't there. So I should have learnt something at that point, I think. So what I'll talk to you about this morning is what did I see during that period when the cat was away and everyone else kept the place going. So the green button, hopefully. No, that green button. Big green button. Okay, so hopefully my other mic is working now. I am a wanderer. I will limp towards the end of this because I broke my foot 9 weeks ago, but I can't help myself. So, the man on the left, for those of you who are not Kiwis, I think there was one Kiwi in the room. So this is our current treasurer. And on Tuesday night, he had the unfortunate duty of bringing down the budget for next financial year. We in healthcare, we kind of had this identity issue where we like to think of ourselves as, why wouldn't you give us money? You know, there's the trust me, I'm a doctor. Trust me, I'm a healthcare worker. We believe that every dollar that we're given is well spent, and it, you know, probably largely is. We do it with the best of intentions. So, you know, we kind of have this Florence Nightingale sort of image of ourselves. You know, we're the Mother Teresas of the world, because looking out at this room, most of you are female. You know, trust me with this money. He had that difficult challenge on Tuesday night of saying, well, how much money should really go into healthcare? And his reality is not that we're the stuff of dreams. We are the stuff of his nightmares. Which is why on Tuesday night, as we were sitting there looking at Auntie, sort of wondering what he was going to give to us as a gift this year, we went, really? A Medicare freeze for a total of 6 years? Is that the best you can do? And that's because our reality, our perception of who we are versus the realities of the environment within which we play have become increasingly divergent. And I'd like to talk to you about other countries that have been through exactly this same journey. In fact, they're further down the path than we are, and the solutions they've come up with. So we've kind of got an insight into what that solution might look like. So about a month ago, the Primary Healthcare Advisory Group that was formed by Susan Ley as the incoming Minister for Health pulled together a group of people and said, what can we do about primary healthcare? That was the report that they brought out just over a month ago. And in that report, they said, we shall have a pilot of 200 healthcare homes. Because we being conservative Australians, we wouldn't just go with it, would we? We'd have a pilot first. So come 1st of July 2017, we shall have a pilot of 200 healthcare homes. The reason there's a canary up there in the corner is because at Inala Primary Care, our patients get sicker earlier, more often, and have less resilience in dealing with their diagnoses than patients in most other catchments. So we like to think of ourselves as the canary in the coal mine. When I saw the AMA media release and the RACGP submission to the Primary Healthcare Advisory Group last year, and in it for the very first time, both of those bodies said, can we please have a healthcare home? I almost needed to consume a whole bottle of red wine to myself. I never thought that I would see those statements being made so quickly by both of those groups. But they've understood the message that I've been talking about ever since. Well, in fact, before I came into primary care, I'm 4.5 years young in primary care. And it's because, having been at Inala Primary Care, I'm even more committed to the fact that we need quite a different model of care. So, healthcare homes, we're going to have this trial. I've already started hearing two polarised views. There's the, oh my God, this is going to be awful. What are they bringing? The House of Horrors story. And then there's the, oh, isn't that what they do in England? Story. Haven't you heard about the NHS? Everyone's leaving, it's terrible. I actually spent a month in England last year as part of the trip. And let me tell you, I didn't see too many healthcare homes in England or Scotland, both of which I visited. I saw a lot of healthcare happening. I saw a lot of great stuff happening in the NHS. But to equate healthcare homes with the NHS would actually be the first mistake that we could all make. And likewise, to assume that healthcare homes arose in the UK is also another mistake. Another thing that happens with change, and we're dealing with change, I'm not here to tell you how to suck eggs clinically, that's not my background. I'm here to talk to you about how do you get the most out of a changing environment. So in a changing environment, you can do this. The not invented here syndrome. And that's what's happening with healthcare homes. We're already starting to hear about, oh, isn't that what they do in the NHS? That's what destroyed the NHS. And oh my goodness, we couldn't have the American healthcare system, could we? Oh, no, they're the most expensive healthcare system in the world. Why would we go there? Oh, the New Zealanders, well, they've only just begun primary healthcare, less than a decade. What would they know? It's already starting. It's not invented here syndrome. My message to you is that we will invent it here. That is what will make it work. Because there is no such thing as a healthcare home. There's a framework, there's a vision, there's a work in progress. How we customise it to ourselves is really up to us. So it's actually quite an old model. It's got more than a decade of experience in other parts of the world, so we can choose to pick the best of the eyes out of the opportunity. I did actually, with that other picture, try and find a picture of the wall that Donald Trump is trying to build. But unfortunately, I think his language is even bigger than his vision for the wall, so I couldn't find that picture. So healthcare homes. As I said, they're not that old really, but they're older than you think. And it's not just about a payment model. A healthcare home is so much more than a payment model. And it's not just about one thing. I've visited a lot of healthcare homes. None of them are the same. And they're not perfect. They are not that answer. There is no one answer to healthcare. This is about an agenda, a possibility. But I think they're our best chance. In the current constrained funding environment, they're the best theme that we can run with. But they're a bit like that little toddler sitting there. They're so new that when toddlers are asleep, aren't they so gorgeous? The little tassel bits of hair, the sweet face, the skin. But when they're awake, and that's kind of what a healthcare home can be a bit like, because they are quite young. So if we're in this change agenda, you've got to have a reason to change. Anyone know what Alpha Piper was? No? Alpha Piper oil disaster? Piper Alpha, sorry. I need my coffee. So in the late 1970s, north of Scotland, 88, was it? Was it that recent? I thought it was 78. Okay, 88. People were off in their oil rig doing their thing, disaster happened, and they had a choice. They could do what they were trained to do, go up into the steel room that they were supposed to go to when bad things happened on the oil rig out in the middle of the ocean. But there are a couple of people that went, actually, this looks really bad. So bad, in fact, I am going to jump into that sea down there that's cold, heaving with waves, hours by helicopter from anywhere else that's land. Who survived? The people who jumped. They had a burning platform. And from that moment on, in the language of project management, change management, the burning platform was born. So I think we hear quite often all of those things on the left-hand side, the growing rate of chronic disease, the multi-morbidity, the staff shortages. We've just seen some beautiful diagrams of those staff shortages. The rising expectations of people coming, seeking care from us, the rising expectations of politicians, the expectations that lawyers will have of us if we ever have to defend our professional practice. The budget constraints, they're all real. I've put a couple of extras there that you don't often see. One is burnout. If that's our reality, so as of 2016, according to the Beach Group in Sydney, who do some marvellous work, more than half of every GP consultation will be with a multi-morbid patient. This is a milestone, it is a landmark, it is a turning point in primary care. There is going to be not that much easy medicine to go round anymore. So burnout becomes a very real factor. From a nursing perspective as well, we have 6 nurses in our practice and growing. There's the question of, actually, doing wounds and IMS is a bit boring if you do it all day, every day. So how do we attract and retrain the very best people into our system and not have them become stale and bored? How do we offer them a career path so that they will leave those jobs in the hospital system where they may be paid an awful lot more than they can be paid in primary care under our current funding models and go on this journey with us? And then, of course, we have the wise man of last century, or one of the most wise men of last century, saying, you know what, if we refuse to change, if we keep doing the same thing over and over and over again, that is the definition of insanity. So that is my plea to you. That is our burning platform. This is why we need to think about things differently. We also need to not be so smug. When I travel around healthcare in Australia, I've travelled extensively, particularly over the last decade with my work. Australians think that we've got it right. We, look at America and we decry their healthcare system. We look at the NHS and we poo-poo it. But if you actually look at the hard data, this is Commonwealth Fund data that compares outcomes across a whole variety of criteria across a whole bunch of countries. Australia's fourth. That's pretty good for a country of 24 million people. However, it's not great, because what's not showing up in that figure is that we actually have the second youngest population in the OECD behind New Zealand. So we actually haven't seen the worst of it yet. We haven't seen the worst of it yet. It's about to come. And for those of you that were at the PHN workshop on Thursday, you would have seen some of that data that says the tsunami is about to arrive on our shores. So, in my world, where the tsunami's already arrived, because we have these seriously multi-morbid people, so 23% of the patients attending our practice have diabetes. That is slightly above the national average. So what I said was, well, if that's the reality, I need to learn from others, because the world is no longer going to continue to exist in the way in which I imagined it. So, I could have said this is a crisis, I could have whinged, I could have cried, no one would have listened. So that little character on the right-hand side, does anyone know what that character is? It is the simplified Chinese form of the word crisis. Does anyone know what makes up the word crisis in the Chinese language? The two little icons are danger and opportunity. So in a world like this, we can choose to go danger, batten down the hatches, become even more conservative, or we can choose to go, hang on, opportunity, what is in it for us? My message to you today, the take-home message, is that there is more in this opportunity for nurses than there is for any other healthcare professional. So if you listen and you listen hard, and hopefully you see what I see through my eyes, and make it your own vision, I actually think you've got an amazing future ahead. So they're the countries that I visited. I was away for nearly 3 months, 15 air flights, no lost luggage during that time, but I was shot at in America. So I want you to develop, hopefully, through my enthusiasm, a burning desire for this new vision called the healthcare home. Because again, in the language of change, it's all very well to say, okay, I'm going to jump off, but often people go through that valley of death in a change process. They change for a little while and then they revert to form. So only by having that really burning desire to want to embrace the new will it continue. So what is this healthcare home thing? I get asked that quite often. This is a simplified little icon that describes what the healthcare home is. So we might start from the left, which means I'll walk left. So starting from the bottom, hopefully there's a pointy thing here. Yes, there is. So continuous. The first piece of a healthcare home is that you will provide continuous care for a patient. So that means that from cradle to grave, you will be there for that patient. You will be able to provide all of the things that that patient needs, unless they need seriously acute machinery that goes whiz, bang and pop, in which case they'll go to a hospital. But you really are there for that patient for the duration. Whereas at the moment, a lot of the medicine we do is, oh, I'll do that bit and then flick, I'll do that bit, flick. And GPs have a rather notorious reputation for being referral writers. Get them in, get them out, get them in, get them out. All of a sudden, we're changing the model of care to being a more continuous cradle-to-grave process. Which means it needs to be more comprehensive, which means that the skill sets that we currently have need to become broader. It means that we need to bring other people into the team so that they, in turn, have the skill sets that the patients are going to need and benefit from. So we're starting to talk much, much bigger teams. You know, we heard from the lovely doctor from Medibank how when she started in primary care 25 years ago, they didn't have nurses. Practices that I've visited, you've got non-dispensing pharmacists, you've got nurses, you've got psychologists, you've got social workers, you've got addiction and drug and alcohol specialists. You've got a whole variety of different sorts of nurse types. You've got a whole variety of allied health. It's like a team that none of us could ever have imagined, because nurses really in primary care only go back a decade or so. These places are highly accessible. Why? Because when patients get sick, they need to be able to get in and be seen. So all of a sudden, I run a private business, and by the time I drop my children off at school, and then I get to the practice, and so I'll open it at 9, and then because I get fatigued seeing all of this constant stream of patients every 6 to 10 minutes, I can really only cope by, 4 I'm buggered, so, the doors close and I go home. That's actually a very doctor-centric model, and it means that patients, because of course patients get sick between 9 and 4, don't they? They then can't get in, so they go to the emergency department. So part of the obligation for these organisations is, in fact, to provide the sort of comprehensive extended hours care that patients require, so that you are there when they need them. It also means that you become patient at the centre. That's why it's at the apex of the little building there. So the patient and their needs, their priorities, who they are, not who you are, because often the patients we serve have different education, different expectations, different capabilities to us as healthcare providers. So your whole model of care needs to be about them, not what you would prefer to give to them, but what they need. It's a very different starting point. It's also about their families, their carers, because it's not just the patient, is it? In primary care, one of the things that we love about primary care is that we've got intergenerational contact with these amazing families. It's one of the things we love. It's also a resource that we need to draw upon. Another part of the system is that you'll be given different sorts of funding. So you'll be given a bundled payment of funding, and it's like, hey, go for it. Design a model of care that suits the patient. If you want to give all of the money for them having allied health, bit of nursing, and whoo, there's a doctor's visit just in there, but that's about it. It will be more up to you to design your system around that way, because you will just get the block of funding. So you will wear more risk about how much does it cost to wear this patient, or to hold this patient. Whereas at the moment, if the patient comes in, you just keep billing Medicare, and that sort of can become an infinite sum. That's why you are the stuff of nightmares for the Treasurer. That's why the government has removed nurse billing item numbers and restricted what GPs can do, because they thought that by standing on it and pushing it down, they'd stem demand. When you've got that many sick people, they've got to try a new option. The new option is going to be the money is yours, do the best you can. Some patients, you'll break even. Some patients, there'll be a surplus. Some patients, you will make a loss, and you'll need to rethink your system and your models so that that doesn't happen too often. And you'll need to coordinate this team to make sure that you don't make a loss, that you do address the needs of the patient, that you do it in a way that's safe, efficacious and satisfactory, and that doesn't burn out your team. So your management challenges become a whole lot bigger than anything that you've ever faced before. But you know what? You're doing it with other people that are equally committed, so it could be the most fun part of your career yet. Now, some of you might be going, but, healthcare home, I see some of my patients so often, it feels like it is their second home, and we're also caring anyway. Hopefully, from what I've just said, I've painted a very different picture of what the healthcare home is. So they're two of the team that I'm privileged to work with. Let me tell you, they're very caring, they're very organised, they're very professional, but it's going to take more than that. And as Churchill reminds us, it's no use saying you're doing your best. If you're going to succeed, you have to do what is necessary. And defining what is necessary is really going to be part of the challenge. So what does it mean, the broader implications? So it means that the personalised patient care and real planning goes at the centre of everything that we do, and then we work backwards. So it means that the sort of commissioning that we have in terms of the way we're funded, in terms of the way we interact with other allied health providers and other people we're interacting with, becomes about the patient. It means that we need to inform and engage our patients in very different ways. In 6 to 8 minutes, it can be very, very hard to really get to the heart of what it is that's driving patient behaviour. If you're spending a lot more time with them and you've got a lot more opportunity to educate them, their carers, understand their context, you can have a much more engaged patient who is in turn becoming the main source of care. And the reality is they kind of are anyway. They spend about that much time with us, in a year, and the rest of it's kind of up to them already. And then the healthcare professionals are really about partnership working together. There are no silos, there are no going behind the door and closing it and you never quite know what's going on in that little black box. It is about a true team of care. It's also about a neighbourhood. So we've said we'll pilot healthcare homes. The reality is those healthcare homes will grow into a health neighbourhood because GPs cannot do it all alone and be contained. So you will start bridging into the community sector. You will start bridging into the hospital sector because together you are much stronger than separately. And the result that we'll all be looking for and will increasingly be measured on and that we'll increasingly be asking ourselves about is what are the outcomes that we're trying to achieve. So the good news is that primary care in this model of the world of healthcare actually is first. At the moment, who feels like the hospital system gets first, second, third and fourth and then we kind of get the crumbs at the end of the table? In this part of the healthcare system, primary care is first foremost. So what does that mean? It means that we need to be more responsible for chronic disease. This is our main job, not our other job. And in primary care, I think sometimes we think of chronic disease as the other job. It needs to become the core job. We'll get incentives for the way we work, whereas at the moment we get incentives for activity. Very different. We move from volume to value. We'll get rated. We'll find out how we're going versus how other practices in this same network are going, and we'll have to ask ourselves questions. Why are they getting better outcomes with their hypertension than us? Oh my goodness, look at their rates of immunisation. What are they doing that's different to us? Whereas at the moment in primary care, it is a black hole. I have tried and tried and tried. I'm a fairly data-hungry kind of person. Those of you that were there on Thursday, you would have noticed already this is not a very data-hungry presentation, so you're probably going, oh, thank goodness. But I've looked for data, and I can't find it in primary care. That's going to change. And we'll all be using data to make better decisions. And we'll be using the patient to make those decisions, to actually make us accountable. A lot of places that I visited overseas, patients are part of the audit process that you have to go through for accreditation. There are patient panels and patient boards and all sorts of other things that are part of the management structure. Because if you take taxpayer dollars, patients become representative of taxpayers. So, making the first step. Okay, I can go from being a healthcare home, where I am now, to a healthcare home overnight, because it's a different funding world. Maybe not. It's actually a long journey. So everywhere that I visited, they said, it can take, and you'll lose people along the way, you'll gain other people. So if we're going to have healthcare homes starting 1 July 2017, we're actually behind the 8 ball already. So we need to get moving and moving fast. We also need to do it with an attitude that's not common in healthcare, and that's about accepting failure. We will make mistakes along the way. And again, my new guru, given that I'm a Churchill fellow, is Winston Churchill. So success consists of going from failure to failure with no loss of enthusiasm, because it's about the journey. So what can we use to guide this journey? We can use these things. They come out of a wonderful group of research academics who are all primary care physicians based in San Francisco. The 10 building blocks of primary care. So they did a lot of work looking at what differentiates high-performing primary care organisations from others. And this is what they came up with. So the first thing is that you've got to have a leadership team that get it. They're like, yes, we want to do things differently. If you haven't got that, you almost haven't got to first base. But the good thing about this 10 building blocks model is that you don't start trying to do stuff in all 10. You pick those areas where you've already got some momentum, you've already got some interest, and then as you start opening the box and people start going, gee, okay, we better change, it then starts radiating out to other parts of the system. So, engage leadership. And that's across the board, practice managers, nurses, doctors, all of the people that have a leadership role. It's about data. So you've actually got to have the right information available at the right time with you feeling confident and comfortable that that data is something you can rely upon. I know a lot of us at the moment look at our patient management systems and the things that are in there going, ooh, don't know whether I can rely on that. Just look what's happening with the My Health record. Oh no, we don't want to upload a shared health summary because it takes too much time to edit all of the stuff that needs to go in it. Well, why do you need to edit it? Shouldn't it have been right in the first place? Empanelment. So that's the American term for having patients enrolled at your practice. It's very hard to provide comprehensive care for them if you don't know what they've done between visits because they visited another doctor's surgery along the way. So having patients enrolled, voluntary enrolment is part of the healthcare home model that we will be trialling because you can't be responsible for managing a budget for a patient if you're not the only person that's managing their care. And it's voluntary. It's a bit like no jab, no pay. You can choose to not have your immunisations. You just lose your family payment benefits. You can choose not to be part of the healthcare home and not enrol in a practice. It's just that you won't get access to all of that sort of care. It's team-based, and I'll show you very shortly some of the sort of team-based things that it means. Patient-team partnership. So it's not about doing care for patients, at patients, to patients. It's about doing care with patients. It's also about population management. So as you get your data sets right, you'll be constantly trawling through the data going, oh my goodness, I didn't realise we had so many 16 to 18-year-old mums, giving birth. I just thought there was a smaller group than that, or I didn't realise that I had so many patients that look like this or this. And that's when you start designing specific interventions, a lot of which can become nurse-led, to address those particular, big spots in your data set. It's also about continuity. So what you will find increasingly is that a lot of patients go, oh, that's my practice, but they might not necessarily have a preferred doctor, and they almost never have a preferred nurse. In this system, they will have a preferred doctor, preferred nurse, preferred pharmacist. They will start connecting to a team, and it's actually that continuity that in research is showing you get the best outcomes. Because you don't have to explain yourself, everyone kind of knows what's going on with the patient because there is that continuity of care. Prompt access to care. So in Australia, data that came out from NAPA last year was talking about on average 3.6 days, I think was our average to get an appointment here in Australia, unless it's an acute appointment. Is that prompt enough? Is that not prompt enough? Who's to judge? But nonetheless, getting right care, right time, right place becomes really, really important in this model. Comprehensiveness and care coordination. So there's that care coordination word, great opportunity for nurses and non-nursing support to be involved with making sure all of the ducks line up in a row for these patients. And then finally, number 10, the template of the future. A bit of a weird term, that one. What it basically means is it says that there's a whole lot of stuff happening outside of healthcare. Sometimes we get so caught up that if it's not within healthcare, it doesn't exist. But there's an awful lot of great stuff that's been happening in Toyota for years and years and years that the rest of the world's borrowed for lean manufacturing. There's great stuff that's been happening in terms of the technology space that heaps of other systems have adopted, right down to the restaurant that I go to where my kids love sushi and stuff like that. So, you sit there on the iPad and you order your food and it magically arrives at your table. There's tons of stuff happening out there elsewhere. So how do we deploy and re-employ and repurpose all sorts of technologies to support the type of care that we want to provide is what number 10 really means. The other thing that we need to do is we need to kind of go, okay, well, you can get so busy with activity sometimes. Have you ever been involved in a project where the actual project becomes more important than the outcome? So this is really about saying, there's been a lot of research done saying there's three things we need to focus in on healthcare. We need to enhance the patient experience, improve population health and reduce costs, and whammo, we'll have great stuff happening. What then happened was we started pushing all of those three so hard that we lost the perspective of who was doing this, who was involved in the system. And we ended up with too much burnout happening in primary care and other parts of the healthcare system. So they've now started talking in the last 18 months about the quadruple aim. And these are the four things that we need to keep in mind and measure as we're working in this new world. So, the new world. The patient is at the centre. Patient is central, they're engaged, they're the driver. Most patients are going to say, I want care happening locally in my community. I want to know who's doing care to me. I want to have a relationship with that team. I want a medical home. I want them to partner with me. I want them to treat me like an adult. They will also say, you know what, this is a health system, it's not a sick system. It might be a sick system, but it's supposed to be designed about healthcare. So wellness and prevention needs to be an increasing focus. Another part of the world needs to be, actually, I kind of want all of the things joined up. yes, I might have a disability, but how come I've got to fill paperwork out and explain the same thing 5 times for 5 different organisations, and can't it all happen more seamlessly? So that's where that healthcare neighbourhood starts playing out. So I listened to something that I think Brian said earlier in the conference, and he said, we will know that healthcare reform has happened when you actually get patients going, my goodness, I'm ready for the doctor now. I have been there. So those little pictures there are from a Virginia Mason healthcare facility in Seattle at a place called Kirkland. It's the suburb immediately adjacent to where Microsoft has their major facilities. So it's very leafy. If anyone's been to Seattle, they have lots of conifers, and it's the most rained upon city in all of America, but it is a beautiful city. So when I set up my sort of internship with them, I thought it would be like everywhere else that I went. I actually arrived on day 1 and I came up through the lift, custom-built facility for 90,000 patients. 90,000 patients. That's why I went there, because I actually went in going, these people are not going to provide great care. I was very suspicious about it. That was my mindset going in. So anyway, I arrived, came up in the lift in this custom-built facility. There was no waiting room. There was a series of lounge chairs, there was a person there, and I wandered up and said what my name was, and they went, oh yes, we've been waiting for you. And they gave me, as you will see on, so this little RFID tag. So we've been using them for decades in food manufacturing, for example, to monitor where goods and service or goods are in large warehousing facilities, etc. So they gave me this little tag and they said, we've assigned you to the beach team. So their facilities they design in squares, and there's like 4 quadrants. You come up in the middle. So I was part of the beach quadrant, and the colours, the paintings, the whole lot are all, so there was beach, mountain, I don't know, it was all geographic stuff anyway. So I was part of beach. So I took my little RFID tag, which sort of attached to me, and they said, you need to go to room, beach 101. So I wandered down the corridors myself, self-navigated. I was all by myself. Found room 101 or whatever it was, and the door was open, and I was like, whoa, what do I do here? So being an inquiring person, I wandered into the door, and I then took a picture of that. Place your badge here on this hook. And I went, oh, okay. So I put my badge on the hook and sat on the chair and waited. I kid you not. Within less than a minute, somebody opened the other door, and I was face to face with somebody. I was like, wow, this is a bit weird. Why? Because they have a Wi-Fi based system in their facility that shows where the tags are, who owns the tag. Clinicians all wear the same RFID tags. So you know how when you're wandering around going, where's Dr. So-and-so, and you spend 3 hours trying to find them? Nope, you can follow them electronically. They actually have up on the walls, as I later discovered, because there's different colours, so you can see, who's who and what's what. So you can always find somebody in this system. So no waiting room, self-check-in. How can they do that? How can they get rid of a waiting room? This sounds like, some sort of nirvana, really. They have used the Kaiser Permanente and Wagner models and whatever ad infinitum. So they stratify and stratify and stratify and risk manage all of their patients, and they only have patients coming into the facility who actually need to come in for a face-to-face appointment. An awful lot of care happens on the phone, virtually, at home. So it's much easier to manage the traffic flow. And when you look at the statistics, all of those statistics came out of the Primary Healthcare Advisory Group report. We have the same sort of patients. So what do these sorts of organisations do? Basically they say fewer patients come into the facility, and when they do come in, they come in for a longer period of time. So a lot of these facilities, doctors have a minimum of a half-hour appointment. A minimum half-hour appointment. Because they're only seeing the doctor when they need a whole lot of workup done. Which means that what do you do with the rest of the patients? Well, they're actually seeing other people who are working at the top of their licence, to the top of their scope of practice, and getting all of the other stuff done that needs to be done. Which means you need quite different facilities, you need quite different management, you need quite different systems. But overall what you end up is less waste, less time spent queuing, and much better financial returns. So I was in New Zealand just over a week ago. I went to Midlands, so that's one of the other big primary healthcare organisations. PHOs are a bit like PHNs-ish, sort of. So they're somewhere in the middle. Money comes through from the District Health Board, goes to the primary healthcare organisation, they in turn subcontract to GP practices. So the Midlands Healthcare Group, so they're a PHO with 100 and something or other GP practices attached to them, is based in Hamilton, sort of 2 hours south of Auckland, and they have this separate group called Pinnacle Healthcare. So they have 9 GP practices that they own and run that are healthcare centres, healthcare homes, and then the rest are actually other GP practices that are part of, have decided to be healthcare homes as well. And they all operate under this banner of Pinnacle. They use that as sort of their evaluation and branding kind of work. So I just quickly want to run through with you, how does a day work at a healthcare home just across the ditch? Well, we all know that about 7:30, 8 o'clock in the morning, what starts happening in any GP practice around Australia? The phones go nuts. So to be a healthcare home in the Midlands model, it is compulsory that you sign up to their centralised call centre. So you don't have receptionists in the way that we have receptionists now. All phone traffic goes through a centralised call centre that is run by the Midlands PHO. So they have that. So this is actually a picture of part of the big call centre that they have. It's not actually that big. So 23 GP practices, some of them are quite sizable GP practices with more than 10,000 patients enrolled. They actually only have 18 people in that call centre. And they're dedicated to little teams, and when the phone comes through, they can tell which practice it's coming from. And so it feels like you're being, in touch with somebody within the practice that you associate with. So they take all of the calls. About 70% of those calls are triggered because the patient has got a recall or a reminder letter. So the patient rings up and says, can I have an appointment for such and such? And they can kind of all see it on the screen, book the patient in. 30% of the calls need to go somewhere else. So what's happening when the phones are going nuts at the call centre? In the GP practice, all of the team there are having a huddle. That's how they start their day in a lot of these places. They actually have a huddle. So they're not actually seeing patients at this point. Then clinicians and other people will wander out of their huddle, go into their cubicles and start seeing patients that are booked in. But some of the doctors will actually start their roster of emails and phone calls. So doctors have scheduled email and phone call time. So if I'm at the call centre, 70% of the calls I can book in, 30% of them need to go somewhere. So you actually have a doctor in every practice who you can send these calls to, and they will triage. Yes, doctors triage, and they get better results. Why? Because the doctor can determine in the space of just a few minutes whether that patient needs to come in today, whether I just need to tell them to take a double dose of their medication and see me in 4 days, whether I need to send a PATH form and get them to go and get some PATH and then wait 2 days for that PATH to come back and then I'll see the patient. Whether, in fact, as a doctor, I don't want to see the patient, but they're better off seeing a nurse or a pharmacist or something like that. Quite a different system. So the doctor has determined when the patient needs to visit, who they're going to visit. Nurses spend 75% of their time direct eyeballing with patients. So nurses actually have their own consult rooms, their own consult spaces, and they are treated as an equal clinical member of the team. Doctors generally are rostered, they see 2 to 3 patients, and then they have an email phone break. Then they'll see another 2 to 3 patients, then they'll have a large email phone break, and that's kind of the roster for the day. So going back to the call centre, what's happening over there? Well, mornings are nuts, that's when phone calls are happening. Afternoons, they have a lot of part-time staff that kind of work shorter hours, so some of them go off and pick their kids up from school because it's a fairly feminised workforce, or female workforce. But a lot of the other stuff in the afternoon is all about recalls and reminders, so that there is constant tracking of what patients need and how it's happening. I mentioned team time, these huddle things. So going back to my facility at Kirkland in Seattle near Microsoft, it was built in a square. The entire perimeter of that facility are these corridors, just like this. That looks really messy, and it was, ish. So you can walk around the entire perimeter of the facility and you'll see these banks of 3 and 4 computers and little desks, and you've got doctors, nurses, allied health all sitting kind of side by side at these little desks. And then the patient consult rooms are the inner part of the facility, which is really good at lunchtime because if you need to nip out and you're running late, you can kind of come up and the patients can't see you as you're running late. Not that they do that, no. So that means that doctors and nurses and all of these other people involved in the patient care experience are all kind of together all the time, so they can have huddles throughout the day about, oh, this patient's coming in now. I'm going to be good cop and deal with this bit, you can be bad cop and deal with that bit, and by the way, I've done this part, and so it works really quite well. So, very significant change in the sort of facility form that we're talking about, big investment required to do it well. Okay, on the left-hand side, this is Virginia Mason in the city. They have they have lots of GP practices, but this was from their city. So every Virginia Mason facility I visited, all around the walls where the team stuff happens, you've got all of these flags, and they use RAG, red, amber, green, they use performance indicators, etc. So they're constantly monitoring and improving what they're doing. On the right-hand side is some stuff out of Midlands where I was a week ago. Again, constant data, constant reflection, because they're all using lean. How does lean perform in the clinical world? I was really interested with that. So on the extreme left, you've got that consult room that I walked into and I put my RFID tag on the wall. So you've got an examination chair / bed, you've got some chairs that patients and doctors kind of sit at and do the consult, and then towards the back you've got this incredibly smart cabinetry build. So this bit down here, so the bottom sort of right-hand side of the cabinetry, there's 2 doors, is actually this middle bit here with the doors open. So depending upon what the patient's coming in for, because you have no treatment room, I'll repeat that again, you have no waiting room, you have no treatment room. So the patient comes in, they check in, you know what they're there for because this is a planned and organised system, and you wheel the right trolley with the right sort of stuff. So is it the baby weighing trolley? Is it the suture removal trolley? Is it the pap smear trolley? Is it the whatever trolley? Into this little part of the cupboard. And how do you do that? On the other side, so there's 2 doors into each consult room. So this is from the clinician corridor. You open that door there, stick the right trolley in, and the patient is unaware of all of this stuff. It just seems like magic. So, all of a sudden you've got all these people working to the top of their scope of practice. I need to move this way. Actually, no, I can see it from here, can't I? If I stop moving, I'll see stuff. Okay, so you've got pods, these areas that patients are assigned to, and their homes replacing treatment rooms. You've got volunteers, carers in the social sector involved. You've got medical assistants replacing the work of RNs. So you've got medical assistants going in, doing blood pressure, weight, phlebotomy, all sorts of other tasks that they're perfectly capable of doing. They call it rooming in the US. So they're replacing RNs. So what are RNs doing? Well, actually, they're doing a whole lot of more sophisticated case management, patient education, nurse-led clinics, etc. And they've got community health workers working with them. These are non-clinically trained people who go out to patients in their homes and deal with all of the stuff that stops them from dealing with their healthcare. So you've got community health workers reporting to nurses as well. You've got RNs who've decided they want to specialise in cardiovascular disease or women's health or mental health or whatever it is, who become clinical nurse consultants in primary care. And they run those nurse-led clinics. You've got pharmacists seeing patients as a clinician, and in some cases re-prescribing medication. So if you've been on a statin for 15 years, you're within range, no reason for you to see a GP. Re-prescribing by the pharmacist, in some cases re-prescribing by the RNs too in different parts of the world. Lots of behaviourists, mental health nurses, psychologists, psychiatrists, alcohol and drug specialists, etc., on site, seeing the patient often before the GP does. Nurses working to the full scope of their practice as nurse practitioners, and then GPs doing the really hard stuff. But because they've got the time to do it, it's actually not as stressful. You've also got a system that's dealing with the whole patient, body, mind, and environment. So you're getting comprehensive care. You're dealing with the real issues about why patients are getting sick. And all of these different roles start cascading out. So this is your bit. This is what nurses can, should and must do in the healthcare home. Chances are there's a whole bunch of stuff up on that slide that you're not doing right now and you're like, yeah, I could do that. I'm interested in doing that. So what does it look like in practice? I saw GP practices where that's what it looked like. That's the different career path that a nurse could aspire to in a primary care facility. So clearly there's a lot of training, there's a lot of management, there's a lot of systems, there's a lot of development that needs to go into making sure that all of that comes together. But it will come together because in these sorts of facilities, the one thing I noticed was calm. There was no disturbance to the force. You know, doctors running an hour behind because you'll never believe my day because I just had 3 fit-ins and 2 double-ups and you know, we all come home at some days, I'm sure. I know I do. And you want to get your lightsaber out. You want to go shh. There is no disturbance to the force. It's planned rather than reactive care. They use technology a lot. So this is a group called EORA. They're actually a publicly listed on the stock exchange American organisation who only care for patients over the age of 65. Again, when I heard that, I was like, oh, I want to go and see them. That sounds like a nutty world to me because we all know that as soon as you're over the age of 65, you're much more likely to be multimorbid. And they do it for Medicare funding, which in America means that you only get paid sort of a government rebate, which most American physicians will say, oh, that patient's underinsured, is the language they use. I wouldn't treat them, they're underinsured. They do it for the Medicare rebate that they get. How do they do it? Custom-built facilities. So when I first went into my first EORA site, this is what greeted me. I opened the doors and walked in, and I kid you not, I walked out. I thought I'd got to the wrong address. And I was walking around the, it was a retail shop front sort of facility, and I was halfway down and around the corner of the building, and this girl came running out going, are you Tracey Johnson? Are you Tracey Johnson? Please don't go. And I was like, oh. So anyway, I wandered back into the facility. The reason it scared me is you can't see it very well, but there's actually a full coffee machine there. And that's what greeted me. That's why I thought, oh no, I've just come into the staff room of some corporation, you know. And so I left. And this is their reception desk. It is a table. This one here is the reception desk. They actually had a social anthropologist as their receptionist. She was the most interesting woman. So as I was, checking in, oh my goodness, she was amazing. And before you get to see any clinician in the EORA network, you get your health coach for half an hour. So you arrive and you have a health coach for half an hour before you get to see anyone clinical. And they are one of the most high-performing healthcare systems in the United States, dealing with nobody other than disadvantaged over 65-year-olds. And they do it through a lot of technology and a lot of soft technology. And they do it like all of these other places because data is king. And no, that is not a mistake on the slide. That is actually a series of pictures of robots saying, I love you, because not all of us like data. We might feel it's a bit sharp and mechanical, but you will have data sets for data sets for data sets, and you'll learn to love it in this world, because it's the only way you can manage. Clarity breeds better decision making. And chances are you'll want to join up with some other people in this new world. So everywhere I went, not only were I looking in many cases at quite large facilities, but this is a group in Birmingham, Vitality. So when I was there, they had 9 practices and they just merged with another group, so they were up to 13 practices. They've merged with another group now, and so they're much, much bigger than that. So that little door didn't look anything special. Downstairs was their healthcare home. Upstairs was a call centre, much like you saw in New Zealand, and a whole range of other really, really smart stuff, because sometimes you need scale to do this well. So we're moving in this industry. When my first day in Auckland on my study tour, I was taken out to dinner in this lovely building. It's called the GP. Food is excellent if you're in Wellington. It was actually one of the original GP surgeries. He obviously did fairly well with medicine, 3-storey house, and it's still called the GP, but it's now a restaurant. So, the cottage industry, the doctor at home. This is actually in Glasgow, in Scotland. This is kind of retail healthcare gone mad. So there were 3 GP practices within the one building that had been custom built by NHS Scotland all competing with each other for patients. But it was all within the one building, so it was kind of like 3 GP practices all in the one building, a bit bizarre. And then you've got EORA that I've just explained. So we're on that transition. It won't be up for everyone. In other parts of the world, they've accepted that there will be different types of GP practices. Choose which one you want to be. And remember, this isn't new. The future's already here. It's just not equally distributed yet. I'm taking my team to New Zealand in November, and we're going to spend some time with some of the healthcare organisations over there. All of these places will allow you to come and visit. Take them up on that offer. Don't do that. We do too much of that in healthcare. So my challenge, my parting 2 slides, be the change you want to be in the world, is what Gandhi said. You have the tools, you have the power, you have the mandate. Do your own health check. Remember the people you're working with? We started out talking about change earlier. When you go back from this conference, if you see that your colleagues are down here and they're doing this, leave. There are other places you can work. So the future is in your hands. And hopefully what I've showed you is that the future for nursing is like nothing you have ever seen before. It is exciting. It is not a crisis. There is a little bit of danger, but there is a huge amount of opportunity. So if you want to find out more about my thinking, my work, the top part, the blog, this is the Churchill report that I had to produce and have examined when I got back, so read that document if you're a bit of a nerd. If not, just follow me on Twitter and everything else, and hopefully we can keep talking. There you are.